We'll be breaking down all major concepts covered on the exam. I mean, imagine a pediatric patient where their skin is literally peeling off in massive sheets, but the fluid inside those terrifying blisters is completely sterile.
Right, or picture a surgical patient with this rapidly necrotic infection deep in their muscle tissue who, inexplicably complains of almost no pain at all.
It's wild. Today we're exploring how the skin rarely keeps the body's secrets and how understanding the underlying physiology is, well, the ultimate key to mastering the MCCQE.
Exactly.
I'm Harvey, and alongside me is Donna. We're expert MCCQE reviewers, and our mission is to help you, the Canadian medical student, conquer Section S10, Dermatology, and feel completely comfortable with the exam review process.
But before we descend into the clinical details, we do need to explicitly acknowledge that the material we are teaching from today comes directly from reliable StatPearls articles.
Yeah, good call.
And just a quick note, this deep dive is strictly for medical education purposes only, not medical advice. Any clinical decisions require a qualified healthcare provider.
Absolutely. So when you're sitting for the MCCQE, you are going to face questions that test your ability to differentiate conditions that look, completely identical on the surface.
Oh, they love doing that.
They really do. We're going to start our anatomical journey at the absolute outermost layer of the human body, so the stratum corneum. Two common conditions live here, love to mimic each other, but require totally different treatments.
Right.
The first is Tinea versicolor, or Pityriasis versicolor, and the pathogen here is Molluscum.
Which is such a fascinating organism. I mean, Molluscum is a lipid-dependent dimorphic yeast. Under normal circumstances, it just exists peacefully as a yeast, basically eating the sebum on your skin.
Right, it's just normal flora.
Exactly. The clinical disease only happens when the local environment changes, usually due to high heat, humidity, or, excessive sweating.
So that environmental shift triggers the yeast to transform into its pathogenic form.
Yeah, the mycelial form, it throws out hyphae that invade the superficial stratum corneum.
And because it's lipid-dependent, it makes perfect sense that the rash appears where your sebaceous glands are most active, right? So the trunk, the neck, and the proximal extremities.
Definitely. The patient usually presents with these finely scaly macules, and they can be hyperpigmented or hypopigmented.
Yeah, and that hypopigmentation is driven by a very specific chemical process. The yeast produces a dicarboxylic acid called azelaic acid.
Right, which actively inhibits tyrosinase.
Exactly, and tyrosinase is the crucial enzyme that melanocytes use to synthesize melanin. It's essentially acting as this microscopic umbrella, actively shutting down the tanning process at a cellular level.
That's a great way to picture it. And to confirm the diagnosis in a vignette, you really want to look for the evoked scale sign.
The evoked scale sign, how does that work again?
Well, the scale on these macules is incredibly fine and often glued down by that very sebum the yeast is feeding on. So if you take your thumb and index finger and simply stretch the skin...
You break those weak lipid bonds?
Yes, and a fine powdery scale instantly pops up. Then, when you scrape that scale for a potassium hydroxide or KOH prep, the microscope reveals the classic spaghetti and meatballs architecture.
Classic board buzzword. The spaghetti is the short, stubby hyphae, and the meatballs are the round yeast spores.
Right. And the treatment relies on topical antifungals, typically ketoconazole, 2% shampoo, or selenium sulfide. The patient lathers it on, leaves it for several minutes, and then rinses it off.
But thinking through the biochemistry of that azelaic acid, a really clear clinical trap emerges here. So what if a patient comes back a month after flawlessly executing their ketoconazole regimen, right? They are panicked because their chest and back are still covered in pale patches. So if the skin is still discolored, is that a treatment failure?
Oh, that is the classic MCCQE trap.
Yeah.
No pigmentary changes take months to resolve. If the acid has already shut down melanin production, killing the fungus doesn't instantly turn the pigment factory back on.
The melanocytes just need time to recover.
Exactly. The key to that clinical encounter is confirming mycologic cure, not cosmetic cure.
Right.
If you stretch the skin and there's no evoked scale, or if your repeat KOH prep is completely negative, the fungus is dead.
Yeah.
You just counsel the patient that the biological damage takes time to fade.
Which means escalating to oral antifungals like fluconazole in this scenario would be a huge mistake. You'd expose the patient to unnecessary hepatotoxicity for a purely cosmetic delay.
So don't fall for it.
So let's contrast Molluscum with its great clinical imitator, which is Erythrasma. If a patient presents with a flat, scaly rash, I feel like the immediate reflex is to assume it's fungal.
It is, yeah.
Yeah.
But Erythrasma is an opportunistic bacterial infection caused by Corynebacterium minutissimum, which is a gram-positive rod.
Right, and while Malassezia prefers the broad, oily plains of the back and chest, Corynebacterium thrives in a completely different microenvironment. It loves the dark, moist, frictional zones.
We're talking about the intertriginous areas, so the toe webs, the groin crease, the axillae.
And the visual presentation is fairly distinct if you know what you're looking for, right? Erythrasma causes this very fine, wrinkled scaling, often described as looking like cigarette paper.
Yes, usually accompanied by tissue maceration because of all that trapped moisture. But the definitive diagnostic tool, and this is a massive high-yield concept for you, is the Woods lamp examination.
Oh, yeah. The fluorescence.
Right. When Corynebacterium minutissimum metabolizes, it produces a porphyrin byproduct called coproporphyrin III. When you shine the ultraviolet light of a Woods lamp onto the rash, that specific porphyrin fluoresces a brilliant, glowing coral red.
Coral red. That immediately rules out Tinea versicolor, which, generally yields a faint yellow-green fluorescence or sometimes no fluorescence at all.
Exactly. So you have a localized bacterial overgrowth, which means the treatment shifts entirely. You use topical fusidic acid, topical clindamycin, or in more extensive cases, oral macrolides like clarithromycin or erythromycin.
And there is a brilliant physiological differentiator here when comparing erythrasma of the groin to Tinea cruris, the classic jock itch dermatophyte infection.
Right, because a true dermatophyte like Trichophyton rubrum survives by literally eating the keratin in the skin and advancing outward.
It's advancing outward.
Yeah, so as it depletes the central nutrients, the center of the lesion clears up, and that leaves a highly inflamed, raised, scaling active border at the leading edge.
But erythrasma isn't eating outward in a ring. It's just a bacterial overgrowth sitting in a moist crease. So it presents as a uniform, flat, brownish-red patch without that angry, raised, advancing edge.
That's the key differentiator.
Okay, so that brings us to a natural shift in the pathophysiology. We're moving from normal flora exploiting their local microenvironment to highly contagious organisms that spread via direct skin-to-skin contact.
Right, so the disease model changes from opportunistic overgrowth to active transmission. Molluscum contagiosum is a textbook example here.
Molluscum is caused by the Molluscum contagiosum virus, which is a member of the pox virus family. And pox viruses are unique, right?
Very. They are massive DNA viruses that carry all their own equipment to replicate entirely within the host cell's cytoplasm. They completely bypass the host nucleus.
Wow, so and as the virus builds these massive cytoplasmic replication factories, it physically displaces the host cell organelle.
Yep. If you were to look at a biopsy under the microscope, you would see these enormous pink viral inclusions. They're called Henderson-Patterson bodies.
Clinically, that viral replication forces the epidermis to grow rapidly, and that creates those firm, dome-shaped, pearly papules.
And because the core of the lesion is packed with dead skin cells and millions of viral particles, the center kind of caves in, creating the classic central umbilication.
And if you squeeze it, a thick, cheesy material expresses out. But, the MCCQE won't just ask you to identify a pearly bump. They want to test your ability to synthesize the patient's demographics with the presentation.
Exactly. In a healthy pediatric patient, finding these lesions on the face, trunk, or axillae is totally benign. It's a self-limiting childhood infection acquired through normal play or shared towels.
So you just watch and wait.
Right. The child's immune system will usually recognize and clear the virus within 6 to 12 months. But context is everything.
Yeah, because if a healthy, sexually active adult presents with identical lesions, they are almost exclusively located in the anogenital region.
Which means in that demographic, molluscum is an STI. You absolutely must consider screening for other sexually transmitted infections.
Okay, but the highest yield trap on the exam involves the immunocompromised patient, specifically those living with HIV.
Oh, for sure. When the CD4 T cell count plummets, the immune system loses its surveillance capability. The virus goes completely unchecked.
The lesions become giant, right? Numbering in the hundreds, coalescing into massive plaques on the face and neck.
Yeah, they can become so atypical that they visually mimic basal cell carcinoma or even a systemic fungal infection like cutaneous cryptococcosis.
So in that scenario, I imagine aggressive physical destruction with cryotherapy or curettage is pretty much entirely futile.
Completely futile. You cannot burn away a systemic immune failure. The definitive treatment for giant, widespread molluscum in an HIV-positive patient is HAART.
Highly active antiretroviral therapy. You have to restore the CD4 count.
Exactly. Once the host immune system is back online, it will hunt down the virus and the lesions will resolve.
Okay, so we see a similar interplay between the pathogen and the host immune system with scabies. But instead of a virus-altering cellular growth, we are dealing with a microscopic arachnid, the Sarcoptes scabiei mite.
Yeah, the female mite physically excavates a tunnel into the stratum corneum to lay her eggs and, well, deposit her feces.
Disgusting, but fascinating. The mechanical burrowing combined with the antigens in the mite's saliva and feces triggers this intense immune response.
Which causes the hallmark symptom, relentless, severe pruritus that reliably peaks at night. On physical exam, you are hunting for those linear, thread-like burrows.
And the mites prefer areas where the skin is thin and easily excavated, right? Like the interdigital web spaces of the fingers, the flexor surfaces of the wrists, the umbilicus, and the areolae.
Yes. If you look at those burrows with a dermatoscope, you can often see the tiny mite at the end of the tunnel, with her eggs trailing behind her like a little jetliner trail.
That's a vivid image. Treatment requires aggressive environmental management. You prescribe topical permethrin 5% cream, applied from the neck down, and left on for 8 to 14 hours.
But remember, because permethrin only kills the live mites and not the unhatched eggs, repeating the treatment in exactly 1 week is mandatory. You have to kill that next generation of nymphs as they hatch.
Or you can use oral ivermectin as a systemic alternative, which is particularly useful for institutional outbreaks.
Right, and you must treat all close household contacts simultaneously, whether they are itching or not. Plus, you have to launder all clothing and bedding at temperatures exceeding 75 degrees Celsius.
But there is a severe variant you need to recognize on the exam: crusted scabies or Norwegian scabies.
Yes. A healthy host mounts an immune response that limits the mite population to maybe like 10 or 15 bugs on the entire body. But in an elderly or profoundly immunosuppressed patient, that inflammatory check is just missing.
So without the host immune system actively fighting back, the mites breed exponentially. You end up with a mite metropolis, literally millions of mites driving the formation of thick, hyperkeratotic, crusted plaques.
And they are shedding highly contagious bugs into the environment with every skin flake. It's highly infectious.
But even in a standard infection, there's a fascinating delayed reaction. Let's say a patient comes back to the clinic 2 weeks after completing their second permethrin dose. They washed their sheets, they treated their family, but they are still scratching endlessly.
It's incredibly tempting to assume the permethrin failed and just write another prescription.
Exactly. So do we retreat them?
No, the clinical reasoning there requires understanding the mechanism of the itch. The Pityriasis of scabies is a type 4 T-cell-mediated hypersensitivity reaction.
Ah, so the permethrin successfully paralyzed and killed the mites, but
But the dead mite bodies, the empty eggshells, and the feces are still physically embedded inside the stratum corneum. The immune system is still reacting to those trapped antigens.
and because epidermal turnover takes roughly 28 days for a cell to migrate from the basal layer and shed off, those dead antigens are going to remain in the skin for weeks.
Exactly. The patient is experiencing post-scabiatic itch. Bombarding their skin with more permethrin will only cause a severe irritant contact dermatitis, which just compounds their misery.
So the correct management is pure symptomatic relief. Topical corticosteroids to calm the local inflammation, and oral antihistamines to help them sleep until the skin physically turns over and sheds the debris.
Right, and that concept of epidermal detachment provides a perfect bridge to a condition that attacks the integrity of the epidermis on a massive scale.
Yeah, up to this point, the bug has been living directly inside the skin lesion. Now we're examining a pathogen that operates from a distance, using chemical warfare to destroy the skin barrier without ever stepping foot in the rash. Let's talk about Staphylococcal scalded skin syndrome, or SSS.
The mechanism here is both brilliant and terrifying. The infectious agent is Staphylococcus aureus, typically a methicillin-sensitive strain, so MSSA.
But the actual bacterial colonization is highly localized and often hidden, right? Maybe sitting quietly in the nares, the conjunctiva, or the umbilical stump of a neonate.
Yes. From that distant base of operations, the bacteria synthesize exfoliative toxins A and B. These toxins enter the bloodstream, creating an exotoxemia.
And these toxins are serine proteases. They circulate hematogenously until they reach the epidermis, and their target is exquisitely specific. They cleave a single adhesion protein called desmoglein 1.
Desmoglein 1 is a critical component of the desmosomes, which are basically the structural rivets holding the keratinocytes together in the zona granulosa, the upper compartment of the epidermis.
I always picture the epidermis as a brick building. Desmoglein 1 is the specific mortar used only on the top floor. When the exotoxin dissolves that specific mortar, the entire roof of the building just slides off.
But the lower floors and the foundation remain entirely intact.
Exactly. This rapid superficial detachment results in sheets of peeling skin. It primarily strikes children under the age of 5, right?
Right, because adults have mature kidneys that rapidly filter out the exotoxin, and they usually carry neutralizing antibodies anyway. An adult only develops SSSS if they're in profound renal failure or severely immunocompromised.
Clinically, the child presents with fever, irritability, and diffuse, tender erythema that rapidly progresses to incredibly fragile, flaccid bullae.
And when these bullae inevitably rupture, they leave massive swaths of denuded, weeping skin. This superficial fragility yields a positive Nikolsky sign, where even slight lateral pressure on normal-appearing skin causes the upper epidermis to shear right off.
That highly specific targeting of desmoglein 1 creates the ultimate diagnostic differentiator on the exam. Because the toxins only destroy desmoglein 1, any tissue that relies on a different protein for its structural integrity is completely immune to the damage.
Right. The mucous membranes of the mouth, the lips, and the eyes rely on desmoglein 3. Therefore, SSS completely spares the mucous membranes.
That is so high yield. If you have a patient with massive total body skin peeling and severe bleeding crusted mucous membranes, you are looking at an entirely different pathophysiology, like Stevens-Johnson syndrome or toxic epidermal necrolysis.
Exactly. You also have to consider the diagnostic workup. When you're confronted with a child whose skin is peeling off in sheets, the visual impact strongly suggests a massive local infection.
So since this looks like a massive skin infection, we should swab the blisters for blood cultures, right?
That's the reflex. But relying on our understanding of the mechanism, the blister was formed by circulating toxins, not local bacteria. The blister fluid is actually completely sterile.
Oh, wow.
Yeah. And furthermore, because the organism is localized to the nares or umbilicus, blood cultures in pediatric SSS are almost always negative. You have to swab the distant source to identify the staph strain.
Management requires immediate admission, often to a burn unit, because the loss of the stratum corneum means the patient is rapidly losing fluids, electrolytes, and core body temperature.
You have to initiate aggressive IV fluid resuscitation and prompt IV antibiotics. You target MSSA with nafcillin, oxacillin, or cefazolin, or MRSA with vancomycin if the local antibiogram or clinical picture demands it.
And crucially, you must avoid NSAIDs like ibuprofen for pain management.
Yes. The massive insensible fluid loss puts their kidneys in a highly vulnerable state, and inhibiting prostaglandins with NSAIDs can easily trigger acute kidney injury.
Okay, so we have analyzed the surface with Tinea and Erythrasma, moved into the epidermis with Scabies, and watched the epidermis detach with SSSS. For our final pathology, we are bypassing the superficial layers entirely and plunging into the deep fascia and muscle tissue.
We're dealing with gas gangrene, also known as Clostridial myonecrosis. This is one of the most critical surgical emergencies you'll encounter on the exam.
The pathogens belong to the Clostridium genus, which are gram-positive, spore-forming, obligate anaerobes. The exam loves to test your ability to link the clinical history to the specific species.
Very true. Clostridium perfringens is the classic culprit, almost always introduced deep into the tissue following severe, penetrating trauma, crush injuries, or contaminated surgical wounds.
But spontaneous gas gangrene, meaning there is no history of trauma at all, is a massive red flag that requires immediate systemic investigation.
Yes, the culprit in spontaneous cases is usually Clostridium septicum. This organism is notorious for its strong association with underlying gastrointestinal malignancies, specifically colon cancer.
So the tumor ulcerates and breaches the mucosal barrier of the gut, allowing the bacteria to enter the bloodstream and seed directly into the deep muscle tissue.
Exactly. Additionally, Clostridium sordelii is uniquely linked to devastating infections following septic abortions, unsterile gynecologic procedures, or the injection of black tar heroin.
And once any of these species establish themselves in the hypoxic deep tissue environment, they unleash a catastrophic weapon, the alpha toxin.
The alpha toxin is a lecithinase, specifically a phospholipase C. It doesn't just inflame the tissue, it biochemically dismantles the phospholipid bilayer of the host cell membranes.
It destroys red blood cells, obliterates white blood cells rushing to fight the infection, and literally liquefies the muscle cells. And as the bacteria gorge on the destroyed tissue, they undergo anaerobic fermentation, producing massive amounts of gas.
The clinical deterioration is shockingly fast. The patient plunges into profound systemic shock, tachycardia, and hypotension. Locally, you will feel crepitus, that distinct crackling sensation of gas pockets trapped deep under the skin.
And the wound often weeps a thin, brownish, dishwater-looking fluid that carries an unforgettable, sickeningly sweet and musty odor. But there is a paradoxical clinical feature regarding the pain that is vital to understand.
Oh, this is a great point.
Wait, why might a patient with a massive necrotic muscle infection actually complain of less pain than expected?
Well, early in the infection, the destruction of deep muscle fibers causes agonizing, excruciating pain that seems entirely out of proportion to what you see on the surface, which might just be some mild, dusky swelling. But as the alpha toxin rapidly advances, it completely destroys the local sensory nerves. So you might encounter a patient with a massively necrotic, dying limb who reports that their pain has suddenly decreased or vanished.
That lack of pain is not a sign of improvement. It is a sign of total tissue death.
Exactly. Gas gangrene is a clinical diagnosis that requires immediate intervention. While a CT scan or X-ray will reveal the feather-like patterns of gas dissecting along the fascial planes, you never delay transport to the operating room to obtain imaging.
The mortality rate approaches 100% without immediate surgical debridement. The surgeons must perform extensive fasciotomies or radical amputations to cut away every millimeter of dead, non-bleeding muscle until they reach healthy, well-perfused tissue.
Simultaneously, the pharmacological strategy is initiated. The patient needs maximum broad-spectrum coverage, usually vancomycin paired with a carbapenem. But the true life-saving additions are penicillin and clindamycin.
Penicillin physically shatters the bacterial cell wall. Clindamycin, interestingly, is a bacteriostatic drug, meaning it doesn't kill the bacteria outright, so why is it mandatory here?
It's because of its specific mechanism of action. Clindamycin targets the 50S ribosomal subunit. It is a potent inhibitor of bacterial protein synthesis.
Ah, so the clindamycin physically jams the bacterial ribosomes, instantly shutting down the production of the deadly alpha toxin.
Precisely. While the penicillin kills the organism, the clindamycin neutralizes its primary weapon.
That is amazing. And beyond pharmacology and surgery, patients frequently receive hyperbaric oxygen therapy, or HBOT. Placing the patient in a chamber at 3 atmospheres absolute forces massive concentrations of oxygen deep into the ischemic tissues.
And because Clostridium is an obligate anaerobe, that intense oxygen environment acts as a direct poison, immediately halting bacterial growth and exotoxin production.
It is the ultimate convergence of rapid surgical action, precise pharmacology, and advanced physiology. We have covered a tremendous amount of ground today, peeling back the mechanisms behind the most heavily tested dermatological and soft tissue concepts on the MCCQE.
We really have. As you continue to prepare, keep in mind that while we study these conditions as localized skin infections, the skin is ultimately a highly sensitive monitor of internal physiology.
That's a profound way to look at it.
A massive outbreak of Molluscum contagiosum is not just an aesthetic issue, it's the body sounding the alarm about a failing immune system and an undiagnosed HIV infection. A spontaneous case of gas gangrene is not just an unfortunate infection, it's a blaring siren demanding a workup for a silent colon cancer.
The skin rarely keeps the body's secrets.
Exactly. When you look at the skin, you must always ask yourself, what is this trying to tell me about the organs I cannot see?
From the superficial flakes of the scrotum corneum to the deep fascia below, every presentation has a mechanism, and every mechanism has a clue. Keep your eyes open, trust your physiological fundamentals, and we'll see you on the next deep dive.